All right, thank you for coming. I really appreciate it. I'm trying not to freak out being on this huge stage. I can't see hardly anybody because of the lights, so it's kind of like doing Zoom, except I'm not in my pajamas anymore. So my name is Darcy. I'm an occupational therapist and an ATP, and I work at the Mayo Clinic in Rochester, Minnesota. And today I'm going to talk about the things that we do in our clinic that can be making the difference when wounds are present. And I have nothing to disclose. So the learning objectives I hope to share with you today is to really look at three important aspects of optimal wheelchair seating and positioning and identify at least two of the underlying issues that can relate to pressure injury development as well as delay healing. And then examine some individual client intervention and strategies that happen either with existing pressure injuries or in the prevention of them. And then I'd love to hear your ideas as well, because this is, again, what we do in our clinic. So when I talk about what's optimal wheelchair positioning, I really like that it really promotes independence. That's the goal. And it's safe and effective, but it maximizes the end user abilities and minimizes any limitations that are present, matches that anatomical and functional abilities, and prevents or reduces the risk of skin or joint deformity. So general seating goals are that we support dynamic seating postures to complete functional activities, right? So we need pelvic stability first. That's the base of support for the rest of the body, especially the upper body. And a symmetric pelvis is best for balance if we can achieve it, and use of those upper legs to really support the body weight that's pressing down. Trunk stability, really achieve and maintain upright midline. That's the goal. I mean, if I have a catchphrase, it's upright midline. And balance the trunk over the pelvis that really frees the arms from providing support. And this is as much in a power wheelchair user as a manual user, because they really don't, even though they're not using those arms to propel, they're using them for everything else, which was the point of power. And then extremity mobility, whether it is for reaching or doing work, MRADLs, or anything fun, and or the legs if they're using for propulsion or any other function that they need. And these don't change even when wounds are present. And that's hard for some people that don't do what we do for them to understand that. But clinical presentation really does matter. And so when it comes to someone who has neurologic conditions, if there's upper motor neuron lesions, you're going to have the quadriplegias, your spasticity, and some of that clonus that really impacts what they need and are able to use. Lower motor neuron lesions, you're going to have the atrophy and the wasting of those muscles as well as that tone. And again, whether it's acquired sometime later in life, at what age and what are they doing at the time, or if it's something that they're growing and aging with, and so function and need is going to change over time. And then there's flexible skeletal abnormalities. So from Mehta et al., 46 to 97% of people with an acquired SCI prior to adolescence are going to have scoliosis, and 1% incident as an adult. So it's a higher risk of people, and I see that a lot in clinic. And higher level injuries and surgical interventions are really going to see those changes. And Charcot spine. So 93% of cases are in persons with complete SCI and paraplegia, and often at the lumbar level. And these can be really debilitating for people, and because of that damage to the spine, now they're really looking at fusion, so what was once flexible now becomes fixed. And then we have fixed skeletal deformity. So 22% of adults with cerebral palsy are going to have asymmetrical hip flexion less than 90 degrees, and they're going to also have some other pelvic obliquities and asymmetric trunk that goes with that. And then the incident and development of heterotropic ossification in the pelvis increases with the onset of paraplegia, spasticity after traumatic injury. And this is one of my clients who developed that within 9 months of his injury at the age of 21. And so had to have a lot of that surgically excised. But it made positioning and use of his wheelchair extremely difficult. And then there's other fixed skeletal abnormalities like girdle stone procedures where things are removed and you've got tissue holding things together, but you've lost your leverage. You don't have the legs connected to the pelvis anymore, so we lose a lot of ways to control positioning. And then amputations, so hip disarticulations, hemipelvectomies, or even just, kind of your basic upper AKA is going to have a lot of positioning challenges because they've lost weight in that leg that helps stabilize their pelvis on that side. So there's just a lot to do. And I think it's really important, as we heard in sessions today that talks about credentialing and who needs to know this stuff, is as an OT, I didn't get a lot of this information in school. And so it was a lot on me to go and find all this information and to start learning these things and coming to ISS and working with manufacturers, reps, to try to understand what it is that I needed to know because I didn't know what I didn't know. So when we talk about the pelvis, again, if it's flexible, we do our best to remediate that. We create a stable base if at all possible and facilitate the strong musculature to hold it in place if we can. And if we can't, then we need a lot of external support. But if it's fixed, we're going to have to accommodate. There's very little that we're going to be able to do to change it if it's fixed unless they're having some sort of surgical procedure. And in my experience with our surgeons, it usually does not end up being more flexible. It ends up being more fixed. But again, the stable base is still the goal, but we're going to use the minimum external supports necessary. We probably have to use a lot softer materials because I have to spread pressure out in places that I wouldn't normally be able to use because of the direction that the person is weight bearing. And then I'm looking for that custom shape capture. So when I talk about the pelvis, I always drill in for our students and any of our new therapists that come in, and it starts with the pelvis. And so you can't just see someone sitting, kind of wonky in a chair and be like, well, if you fix the head and you fix the feet, that should do it. Like, no, the head and the feet are not in alignment. They're not upright in midline because the pelvis is probably not where it should be. And so the goal is to get from those smaller points to the larger surface to distribute pressure, increase that surface contact through immersion, and then envelop the body as much as possible to distribute away from those bony prominences. So that means we look at cushions, right? And cushions, there's cushions for days. There's cushions of all sorts. There's cushions of all names. You can't even keep track of all the cushions. And then everybody wants to drill it down to what's the best cushion. I only want to get one, so what's the best cushion? And we're like, oh, I don't even have time to go over all the options for cushions. But it's important things that we really need to know, and that there's multiple mediums and there's multiple shapes, and not one is going to fit everybody. So the qualities and the properties have to be matched to the unique end user's needs to really get them to get that best position. So when we talk about those cushion choices, for benefits of foam is it's contoured as needed. You can carve it, you can move it, you can shape it. It's pretty low maintenance for the most part, and you can get that variable density and viscosity of 3 or 4 layers of foam, or you can build things up. So it's pretty versatile, and it's relatively low cost. For air, you've got immersion and envelopment to increase that pressure distribution. And it's adjustable to some points, and it's breathable, or it's more breathable than foam, especially in warm environments. But there's, and I'm not even going to say it's cons, it's just considerations, because again, in order to custom design things or configure things for your end user, you want to take all the properties and try to fit it to them the best that you can. So foam, once someone's been incontinent and it didn't have a liner, that's kind of done. And you know it because you can kind of smell it coming when you're getting into clinic. So you want to get that replaced as much as possible, or as quickly as possible. And it's going to compress over time, and it doesn't always compress symmetrically. It doesn't always compress in the places that you would expect. But it also retains heat and moisture. So again, in an environment where there's a lot of heat, it can build up a pretty moist microclimate. But air can be affected by altitude and climate. It may affect the stability and transfers, and that's the one I see most often, is people will be using an air immersion cushion because it's either the best that they needed at that time, or if they've had a wound in the past, but to transfer on and off of it or to feel stable, they often overfill it, or caregivers overfill it because we like things symmetrical. If we can't bounce a quarter off of it, it's too floppy. And I like to tell people it's like a bathtub. When you put the water in it right away, the water is a little lower. As soon as you sit in it, the water level goes up. And that's how an air immersion cushion works. It should be floppy when you're not on it, and it should fill up and envelop you when you sit on it. So then you've got honeycomb and you've got gel, and there's benefits to those. Lightweight and very breathable. Again, pretty low maintenance, and they can be cut to shape in some instances. And some of the honeycomb have been great for filling in for skid loader seats, tractor seats. I'm from the Midwest, so we have a lot of skid loaders and tractors. Motorcycle seats, riding your horse. So there's a lot of those kind of benefits. And for gel, there's immersion and envelopment. That's what it's there to do. And the cooling properties of some of the newer ones are great to try to keep that heat retention down. And you can get different gel viscosities. So there's some that are more fluid and some that are quite a bit stiffer, and so you can kind of match those needs to persons with how much weight they have, how much they move, how much they're kind of moving their butt around as far as shear reduction. So again, a lot of benefits. But there are considerations to those as well. The honeycomb can feel really firm to people, and you really can bounce a quarter off of that sometimes. And it's not easily adjustable and may not accommodate some of those abnormalities in positioning. And if you do too many modifications, you're going to void the warranty, and now you're going to need to provide a new cushion. The gel, again, for some of the considerations with that is the gel disperses, and people don't always maintain it and put it back in the center like they're supposed to, so it stays squished out from the day they use it until they come back and see you and say, well, I didn't know you had to do anything with it. And then it's also based on the cushion design. So sometimes that ischial well can have that variable height difference. And I don't know about you guys, but I find that's a really big deal for people that can get really bony. That shelf that they have to jump up against between the foam and the gel can make a big difference. And of course, it tends to retain heat. So a lot of people, I think, we look at combinations because you're trying to match those different properties to your user, to your client, to your patient the best that you can. And so when we have someone who uses only air and complains about a lack of stability, but they're worried about pressure, then doing a combination of maybe that foam base with the air insert can be a nice way to stabilize the pelvis from the legs, the trochs, the rear buttocks even, but provide that air or gel medium that's underneath the bony prominences to ensure that they get some of that envelopment and a little bit of that more pressure reduction and pressure distribution while still feeling like they're functioning the way they want. And then you need to go to custom. When you've tried off the shelf and it just doesn't match what they need, then custom is a better way to go to really match their needs with the product that's designed for them. But again, everything has a consideration. So migration of the aerogel in the foam can cause those bony prominences to kind of run up against that ledge. And again, depending on the height of that ledge, it can be a 2 to 3 inch jump. And all of a sudden the gel is in the back, the bones are in the front, and they're in contact with the base and nothing that we want them in contact with. And then for custom, weight change affects the fit, especially weight loss because they tend to fall into it. And so the places that you were putting pressure or capturing because you had tissue there, or you had something else to hang on to, if that's lost, then they tend to just kind of sink down into it. And then if it is the most expensive, so if you can't adjust it or they have a significant weight loss, then you're fighting insurance to get something sooner rather than later. So then we move up from the pelvis back into the trunk and really looking at that stability again in that pressure distribution. And so looking at where the spine moves and how they need to move, looking again whether it's flexible or fixed are the next two things we're looking for. And how flexible and how fixed. Is it partially reducible? Is it unreducible? Because that matters as far as how they use their body to function and what they want to do while they're sitting in their chair. So then you got to go with what's the best back options. And again, there's no right answer. or no wrong answer. It kind of depends on matching that user to the needs. But knowing the different shapes, the mediums, and whether or not they're adjustable is really huge, again, to match their functional needs with what's available. So when we look at the benefits of a planter back, it's a flat shell, so it allows for a lot of attachments. A posterior contour creates some adjustability, and the thicknesses can account for some of the lordosis and or building around a kyphosis. But they're not as adjustable for the planter, and they don't slow progression. So if someone has some abnormalities that are developing as far as scoliosis or even some kyphosis lordosis, they're so flat that you just can't do much with it. So you can move out of that fairly quickly. And then with the posterior contour, you're missing that lateral contour shape. And again, with an adjustable tension back, you can only tighten as far as those push canes are wide. So it may start with, it's enough tension, but as someone progresses, it may be not near enough. And you're not going to accommodate significant lordosis or kyphosis with some of these. So looking at lateral contour then, the pros are it's designed to kind of be more in a trunk shape, and so and you can get the depths and heights to better fit the trunk. And custom, it really can be a unique shape capture, but I'll show you one where, I thought it was really good, and it ended up not being really good. So I'm going to share my successes and my failures with you today. But lateral contour, there's not the posterior control sometimes. So someone there, you kind of feel like you've got control of them laterally, but there's this big gap in the middle. And sometimes when you have users who have more lordosis, they complain a lot of low back pain because they're doing well laterally, but they're feeling like they don't have any of that low back support. And so either they tend to slump more and try to get more contact, or they try to sit up taller and they want everything taller to try to contact them and keep them feeling comfortable. And again, with custom backs, I find this to be even harder with backs than with custom seats, is that weight or skeletal changes really affect the function, and it's really hard to reshape that once it's made its initial shape, at least in my experience. And then we have to look at that center of gravity. So if we're using for a manual wheelchair, how much slope do they have, and for what purpose do they need that slope? We can lower their center of gravity and hopefully load more of that proximal and distal femur and use those legs for weight bearing like they're designed, and try to keep as much weight off the ischial tuberosities as possible. But with that, and I see this unfortunately more often than I'd like, is where someone gets some slope, but they don't have a seat to back angle that really supports what they need. Either if it's not closed, I feel like they're sitting in the back seat instead of the front seat, and because they're getting too much recline, and then they end up with like that thoracic collapse as they try to balance and find a center where they can let go with their arms and hands to actually propel. But sometimes people have been in that kind of sloped position for a while and it becomes fixed. So now I need to open that seat to back angle in order to accommodate a pelvis that isn't going to really move anywhere, but I have to provide some of that trunk stability for the same reason. Then instead of them being able to stabilize forward over that pelvis, they have to stabilize back. And so we need back support and for them to let go and start to propel. And again, this kind of changes over time. And as I see with new injuries for persons with SCI, they really want to be in the back seat at first. It feels safe, it feels comfortable, it's easier to look up. But that changes as they get more comfortable with their body, and it changes as they see more people around them and get to know different ways that they can sit. So then they want to be more upright if it's all possible. So then when we talk about that center of mass, so that's different too. So if we have someone's center of gravity and where they find that they're the most balanced, we're trying to look for that center of mass, and where are they in that chair to be able to get the best propulsion efficiency. So again, they might start with the tires more rearward when they're first using a chair because it feels safe. They are not as tippy. But as they need to function in an environment that maybe isn't as set up as it should be or could be, then they need to be able to get over curbs or up over larger transitions. And so they need that ability to have some of that tippiness. So it really comes down to that balance of what they feel they can do, and then it probably takes adjustment over time. So it's not something where it's a set it and forget it. It's a lot of moving that over time to get someone where they want to be. But then with power, it's the same kind of thing. We're going to choose that center of gravity. And so many of my clients, I feel like they like to be at 0, and I don't know why exactly. So they have 50 degrees of tilt, and they like to use very little of it, at least when they feel like they're functioning. But then they do that thoracic collapse. They're often spending a lot more time with forearms on their arm supports, and then their driving is kind of stuck here. So then they're leaning like this, and they've just lost a lot of functional reach. So if I can get them to do even 5 to 10 degrees of tilt as kind of their 0, that helps to stabilize them. And if gravity is a plumb line and it's coming right down on top of my head, the further forward my head is of gravity, I'm going to get pulled away from my supports and I'm going to collapse forward. But if I can be just behind that pull of gravity, I get pushed back into my supports and I get that upward thoracic support, and it's easier to breathe, it's easier to see. But there's, again, that trying to get them to get in that mode and feel comfortable is really important. And then looking at the power tilt and the power recline with those to try to get that full pressure relief maneuver, trying to get that full elongation of the spine to help with repositioning, breathing, and just feeling more comfortable. The range of 25 to 35 degrees of tilt and 10 to 20 degrees of recline with this study seem to have the best effect on tissue and muscle perfusion as far as preventing wounds and keeping things moving, and it tends to provide a lot of support. So there's a lot of ways that it can be done, but it's best if they're used in conjunction together. And then returning to the home position is also really a coordinated sequence. And I like to have people do their tilt first, then their legs, then recline. Because then they stay seated in their chair and they get that spinal elongation. But when they come down, they tend to drop their feet, tilt, and then recline, and then they start getting pushed forward out of the chair. So if at all possible, I like to make sure that we're doing the sequence of the power chair programming in the right sequence for the maneuver that they need for pressure relief, and putting it in the position of comfort for them, and then reversing it so they don't have to worry about that. So then when we're looking at lower extremities, because I've gone from pelvis to trunk to then lower extremities, is elevating lower legs. How many of you get requests for elevating legs on a manual wheelchair? More than all of us want to say, right? And it's where is it coming from? Primary care? Yeah, because they have edema, right? So that's going to help. So I'd like to go through with my primary care providers that it doesn't do the things that they think it's going to do in a manual wheelchair. That really, when someone's a manual wheelchair user, we need those legs to be well supported and not in elevation. They need to be loading, they need to be well positioned, they need to be bearing weight. That's what they were designed for. And if they don't bear weight, then it all goes back to the buttocks. So this is a really key point, and I haven't gotten so much that I would send this slide to them yet, but some of them I've made a good relationship where I feel like I can say it. Or they just asked now, and they said, well, they've asked about elevating leg rests. I said, well, we're not going to do those, but here's what we can do. But in a power wheelchair, elevating legs can be a huge game changer, especially for people with edema. But they have to be combined with tilt and recline, right? Because you have to be able to get the body positioned such that the legs actually are elevated enough to do something. And you can't just elevate them of their own. You need to have that tilt and recline to really keep the person in alignment, reduce the shear, and just keep them positioned well. And then we all want to use that seat interface pressure mapping with the idea of helping us understand where those pressure points are. And again, it's not an end-all be-all, and we stress this a lot with people that it's a form of information and it's a way to communicate, but I like it a lot as biofeedback, because when you can't feel what's going on your sitting surface, but you can see it, and you can see how if you slump it changes your pressures, or if you laterally lean, how far do you have to go to really get no pressure underneath that ischium that's broken down. It can be a huge teaching tool as a way to make sure that person really understands how far that they need to go and what is value add. And then again, as you're doing different cushion selections or different seating positions, it's again giving them that feedback of this is what's different, and here's the snapshot compared to what you're on now. And what do you think feels better? Because again, it's only a snapshot in time. It's not going to tell me what 6 hours of sitting like this looks like, but it can give us an idea of where things are going to go. But then there's wounds that are present, right? So things that even with the best of intentions, things still happen. So we really like to look at the location of the wound, functional activities, their lifestyle, and their goals related to that wound. So if it's sacral, very rarely do we find that a sacral wound is coming from sitting, but sometimes it does, and it's usually a very specific situation in which that's occurred. But head of bed elevation or use of the recliner. How many people do you get coming to your clinic that uses a recliner a lot? Yeah. And back to primary care, like how many hours do you spend in the recliner, and a lift recliner is not going to do it. You know, you need to do better than that. But commodore bedpan are really huge, especially with someone with an SCI where you're going to do your bowel program, and it sometimes takes much longer than it should. And in another course I was in, I think yesterday, that was brought up is, you know, that's a big deal. If someone spends an hour on their bowel program and they're sitting on that commode chair, that's a huge amount of pressure, even if it's not in that large period of time, but on a very small area. So that's a huge place. And how many of our patients, if you work in a hospital like I do, but also an outpatient, I see them, they always have their head of the bed up. Nobody has a flat bed, right? Or the dialysis chair. I know that was brought up a few times, and in our clinic, we have tried really hard to see that if power wheelchair users could use their power wheelchair in dialysis. And the answer for us, and I'm interested to know if anyone else has anything different, has always been no. And the reason why is that they cannot do CPR in their power chair. And we've pushed back a little bit because we said, well, it's got the power seat functions, it can go into full recline, and the people at dialysis are not willing to take that responsibility, so the answer is no. So 3 times a week, they're going to go into that dialysis chair, maybe on an air flotation cushion, maybe not. And even when we could prove that our client's skin prior to dialysis and then after dialysis looked significantly worse, it was no budging. It's going to be the dialysis chair or not. So if it's ischial, we know one of the things that we look at is, you know, okay, is it the cushion? As we've heard, it's not always the cushion, but sometimes it is, and sometimes it has to relate to either the type that they're using, again, whether or not they're actually immersing in it or not, if it's overinflated or not, but also a depth. I see depth as a big issue. And I think you see that when people are doing their anatomical measures, but then maybe are not familiar with how much that backrest hardware is going to eat out of the seat depth. And so what may have been an appropriate seat depth cushion if you were just going to sit on it doesn't work when you have 3 inches of the back taking up that space, and now you've got all that distal thigh hanging off the front edge. And we know when legs hang off the front edge of the cushion, they also go east-west instead of staying north-south. So I also look at if it's a bilateral wound, which one was first? Does that go back to that pelvic obliquity? Do they have a postural tendency where they're going to put more pressure one side or the other? Have they had any type of surgery in the past? Have they had an ischium removed as part of had osteomyelitis, and on a previous flap or other surgeries they've had it removed, so now they tip one way, or they have the other bony prominences is the one that's always going to bear more weight because it's present. And then are they doing effective pressure relief maneuvers? This is where I've had folks that have been wheelchair users for a very, very long time, much longer than I've been doing any of this. It works for them. They tell you that. It works for them. They do it all the time. But something's still different. And so is the wheelchair push-up as effective as it could be? Maybe it needs to stay in their arsenal because it's comfortable for them and they know how to do it and they do it all the time. But can an anterior or a lateral lean being added to that make an even bigger difference with it being not only done, but effective and held long enough to get that perfusion of the skin, which we know takes time, and it's not going to be 10 seconds or less. They're going to have to hold it for a period of time. So then sometimes they have posterior thigh wounds. A lot of that comes back to, are they sliding in their chair? Are they having trouble maintaining their posture? Again, cushion depth. Is it too short and it's cutting at the wrong places, or sometimes too long and it's catching them behind the popliteal fossa and causing pressure there? But it also has to do with lower extremity positioning and support. Are they dangling off their foot pedals, or are they rotating off their foot pedals? And so they're pushing into areas that weren't necessarily intended to take soft tissue pressure, that are artifacts as part of their chair or anything else that they're sitting on. And then lower extremities. So is it contact with the frame or accessories? And my favorite is the metatarsal, right? Like that is going to happen when you have foot that aren't going to stay flat, that aren't going to stay balanced. And so they're either constantly in that rotation and they're putting all of their lower extremity body weight into that metatarsal head, and it's going to break down. But then also helping to have people understand, is this a vascular wound or is it truly a pressure wound from being in contact with the chair? So sometimes someone who's a rigid frame user, they have that tight tucked front end, but their legs are getting pinned up against the frame and there's nothing between their skin and the frame. So it is causing pressure, but sometimes with persons who have venous insufficiency, it's really a venous wound. So it's not related to pressure, but it's related to the fact they're dependent edema. They don't have a lot of great flow back up their body, and so they need help in other ways. And then the trunk, a lot of it is kyphosis and sometimes the gluteal shelf. Depending on where that contact comes from your cushion back or your back cushion it's starting here. So they're getting pressure at that gluteal shelf. And that's where sometimes I see those sacral wounds, is because there's so much pressure from the back here. They're contacting it here and they're leaning on it, or they're pushing as they're trying to get contact in the lumbar spine, which isn't happening because the contact is too low. And sometimes with some of my clients, I have like a 4 or 5 inch discrepancy between the back of the gluteal shelf and the low back. So the only other way to do that is to bring either that back cushion up and fit it into the lumbar spine, or we're going to have to do some more custom shaping to get things covered. And I do a lot of privacy flaps, to keep everything covered, but we really have to fit it into that lumbar spine in order to alleviate that back pain. And this is a gentleman I had who wasn't a wheelchair user, but he'd had spinal tumor, and so had a ton of radiation, which did take care of the tumor, but it just destroyed his musculature and his spine. So he was breaking down. It was protruding through his skin because he was so kyphotic. And everywhere he sat, he put pressure in his spine to the point that it broke down. So then they look at functional activities and how many hours of bed rest do people get put on? Well, it's really dependent on the provider, right? How many people here, you should go to bed? As soon as a wound is found, you should go to bed. It happens, right? Go to bed and, follow up with me in a couple weeks. So what do people do in bed? Especially if they have any way to have the head of bed elevation. And we're not just talking the hospital beds, but the sleep numbers or everything else that has head of bed elevation, right? You can only lay flat for so long, and if your provider puts you to bed, you're going to be sitting upright and on your sacrum or elsewhere. So not only do you maybe have a sitting injury, now you get a lying injury from being upright all the time. And and even if you've got some of the best, support surfaces on the market, they're not designed to have all the body weight hitting in that V. And so you're still going to have a ton of pressure because it's designed to be flatter and distribute the pressure away, not being sat up in it, and you're actually collapsing those alternate air tubes as they're supposed to be moving air through because you're putting so much pressure through them. So then they're not being effective. And then sitting restrictions. So if you do get to sit up, how much and how long and where do you get to sit? Nobody usually covers that. They just say go to bed. So sitting, location, and surface really matters. So if someone's used to doing that hour of bowel care every day, is that where they need to sit in those sitting restrictions, or is that just going to make it worse? So do we need to come up with either a faster method, or do they do that in bed for a period of time in order to get that wound on the right track and also preventing any type of contamination? But part of this too is it manual or is it power? Someone who has a power wheelchair has a lot more options for changing their position than someone with a manual wheelchair if they've got something that's on the sitting surface, right? Because they only have so much space. They don't really have a way to shift it to the back unless they do a wheelie and kind of hang out, which a lot of people do, but how many hours can you do that in a day? So it really depends on all those other factors. And so it's often sometimes a progressive time up to the chair. You got to get up and do the things you need to do. If you're in bed, can you do it more prone? Do you have to always be supine or side lying? And then how long are the restrictions in place? And again, there's very little in the way of any standardization. When I've worked with our plastic surgery department who does all of our flaps, I mean, when we started a project that we did 6 years ago to try to standardize things, it was all over the map. Some people were in bed for 12 weeks after a flap surgery, and then they could just sit up, no restrictions. That doesn't really work. Some people would be in for 6 weeks, then they'd have sitting restrictions, an hour a day for so many weeks, and then they could start progressing up. But it was very surgeon dependent, very provider dependent. And it didn't seem to have a reason or a rationale for each person. It was very much what the surgeon thought their flap needed, not really based on function. And then we talk about lifestyle and goals. So that wound is present. Can they really take time off of work, or do they need that job because that's what's paying that insurance, which allows them to get their wound care or keep them working so that they can pay all the bills that they need to pay, right? Just like the rest of us. Can they really stay home for hours and hours, and then can they just go to bed and still get the number of PCA hours and extra care needed to do the wound care or the extra time that they need for transfers and being in bed? A lot of times too, like I can't miss something. I know I have a wound or I know I need to get this taken care of, but I can't, I'll do that later. I do that after these other big things because just like the rest of us, we don't always prioritize our health the way we should. We prioritize other things and worry about it later. And then looking at those goals of care. So sometimes, if we can catch it early, we don't end up going to surgery, but sometimes by the time we see them, it's already a stage 3 or 4. And so are they someone do they have any surgical options? Are they healthy well enough to be able to do that? And even if they get listed, it's still months away because of the surgical calendars. So quality of life, sometimes the biggest thing is I've had clients say, I'm not gonna go to surgery. I don't wanna deal with that. I just don't want it to smell. I don't want to have that going on. So as long as I can keep doing what I'm doing, I can keep doing the lifestyle I want, and I can reduce the smell, and I don't want to feel any sicker than I already do. That's my goal. I don't want any of those other things. So how can you help me with that? And then sometimes it's that palliative care, saying that's your choice, and you've totally made the choice that you think is going to work for you. So there are ways to support you in that endeavor because you probably aren't going to be a great surgical candidate. So why not do what you want to do with the least amount of restrictions and limitations in place? So I have a few case studies to share that kind of highlight some of the things that I've had in my personal experience. So our first case, she was 26 years old when she came to me, C6 sensory incomplete. paralytic scoliosis, and she came in to our clinic because the surgeon sent her to us because he was considering a surgical fusion, which would basically go from like L2 all the way up to connect with her cervical fusion that you see there. So it was really going to be a significant surgery, and it was really going to change her mobility. She had a stage 3 left ischial pressure injury, and she had a 4-year-old son at home, and she worked 2 jobs. So she was really, really not interested in surgery unless there was no other option. So when she came into the clinic, this was her chair. From first glance, it didn't look too bad, except where's her pressure injury? Left or right? So that's starting to make sense already, that the left side is lower, and in her case is bearing more of her body weight, right? So this is a reason, and this was in another talk early days, take the cushion cover off, because this is what I found. So she had an dish. I'm not very familiar with them, but I know they exist. So her dish had been modified to widen that ischial well, to try to alleviate pressure to the pressure injury that had developed. But the problem was that her ischium was actually drilling a hole into the base of that cushion. So not only did the injury exist, and they tried to make modifications, but the modifications just dumped her right onto that left IT until it started drilling a hole in the cushion. So in her case, we ended up doing custom, and when she went back, and I wasn't able to pull this because it was she left our health system after, but they had done repeat x-rays of her, and her scoliosis was extremely reduced. So she ended up not having the fusion. She ended up getting married. She had another son. Nothing changed in her life except that seating system, and it made a huge difference, and that wound healed up without having to be really aggressive with the scoliosis surgery. So my second case was a 50-year-old man who was working full-time, T8, and he had an intrathecal backlift pump already in place to help with his spasticity, and he got a stage 4 wound, ended up being able to go to surgery right away. This was one of the quickest ones I've seen in our system. But we had seen him pre and post, and we'd seen him probably the year before too, and things looked good on his chair. I mean, we were kind of a little stumped. He was very active, worked full time, and so it was just like, well, where did you think this came from? And I said, well, what's your bowel care? What do you use for your bowel care and for showers? So his wife sent me this. And I was like, come on. Said, what about this picture looks bad to you? And he said, well, only the front's broke. And I was like, okay, all right, well, you're right, but that's really bad, and I think we can do a lot better. But of course, we had to wait for insurance coverage, so we ended up so we did pressure mapping to prove just how bad it was, regardless of how it looked. But then we actually put in a air immersion overlay for the commode to help alleviate some of those symptoms in the meantime that we were working up to surgery, and then getting him a new commode that he was going to use after the surgery so that we didn't have a repeat. But we talked a lot about the fact that when stuff looks like this, you should get rid of it before it looks like this, right? So our third case is 56. He had an MBA in 2003 and had a history of wounds. He's just very, very thin. He is very focused on health and wellness, and he's just got a really, really thin body habitus. So anytime there's even a redness, he's already taken a picture of it, sent it to us in his portal, and hit it as high priority, so that we are making sure we're getting these within 24 hours. But he had this right thigh wound that, it's not a loading surface. There's no bony prominence under there that shouldn't be there. So we couldn't really figure that one out. And so the provider I worked with, I said, let's see what's going on underneath, because it doesn't make sense from what we have. And he's a marathoner. He's ranked nationally and internationally as a hand cyclist. And so we were checking his bike. We were we were doing everything. the whole kitchen sink was going with him. So we ended up ordering an MRI and a 3D image MRI. And I don't know about you, but this is I start nerding out on this, and I start turning it around on the computer screen, and I love this stuff. But come to find out, when they were doing some of their wound care to initially heal that before it got too deep, they actually went down to the bone. So they were creating HO in that area because they were getting too deep because he was so thin that's why it wasn't healing. So we ended up having to go to get just a primary closure. They went in and cleaned out that extra bone, closed it up, healed just fine. So sometimes it has nothing to do with what they're sitting on as much as what's going on inside. And then I have another one, Miss T. She is an OT, so we always had a lot to talk about and had long sessions. But she'd had T4, and her shoulders are really wearing out. But she had been a manual wheelchair user her whole life. She was not interested in changing that. But she was really starting to struggle with how she felt in her chair and was very worried about skin. So she didn't have any wounds at this point, but she was really getting afraid because she was starting to have some recurrent redness that wasn't always going away as timely as she'd like. And her back pain was getting a lot worse. And as you can see from here, it's probably not insignificant, the amount of back pain that she would have given her spinal scoliosis and her pelvic obliquity. So this is her chair. It is a custom seat, but it's custom made, not custom fit. And that became the problem. So her pelvis is not level, her leg length isn't symmetrical, and she's always putting pressure in wrong areas, and it's and the depth isn't right. So for having a custom made seat, it certainly wasn't custom to the things that she needed. Well, when we pressure mapped, it didn't look terrible, but you can see both ITs and her right troch. So she really was weight bearing mostly through her buttocks and those bony prominences and really not much of her legs at all. So we ended up doing a custom shape capture with the back and the seat to really kind of highlight just where things were, and ended up helping quite a bit, although we did back off. And after the shape capture, she really wasn't sure about custom back, so we ended up with going more off the shelf, but kept the custom seat, and that was a better fit for her. And then I have one of my favorite gentlemen. He's got the best smile you'll ever see. He's 27 with CP, and his mom is his primary caregiver, and they love to go for rides. So they're in the car probably 4 to 6 hours a day, because that's what they like to do, and they go out to eat a lot. But he had restrictive lung disease, he had some dysphagia, which was known, it's been known for years, and then his quite significant kyphoscoliosis, and then a torticollis of his neck. He was using a pediatric stroller with very limited head supports because that's what he's always used, and he didn't really grow very much, so it still fit. So when he came to clinic, we just said, okay, well, what do you want to do, Mom? What do you think he wants to do? She's like, I want to try something better. And I said, so we tried some off-the-shelf things, but it just wasn't enough because he is quite fixed in how he sits. So I said, I think we need to do custom. So we did a beautiful custom seating system that articulated exactly the directions that he needed to have supported. And it worked great, fit him like a glove, but it ended up being a failure. And can you guess why? Anybody? Any speech pathologists in here? Anybody? Yes. So what we did in our infinite wisdom was we aligned his head, neck, and stomach for the first time in years. And he was happily aspirating away, is what the speech therapist said. When they did his barium swallow, it was just going straight down, no cough, no nothing, and he still had a smile on his face. So that was not a good idea. So we ended up we modified his seat knowing that it was going to go on a different kind of back, but we had scrapped the back altogether. And we kept the headrest, but had to really reduce that back to where his body's going to be in his normal position, because he was going to die of pneumonia if we didn't do something else. And so again, he was in the best position he'd been for years, but it wasn't functional for him, and it could have ended up progressively ending his life much sooner than not. So this was a failure in the respect of it didn't really work for him, and it caused him to have some of those issues, but we rectified it by saying, it's okay, let's just do something else, and coming up with a system that maybe wasn't as good a support as he needed, but it kept him from aspirating. And then this gentleman, unfortunately, has passed away in the last year, but he was great as far as he knew exactly what he wanted, and he knew exactly how to get it, and had done all the research for you. But he had ended up with a lot of dystonia, and he had so many contractures and a lot of spasticity that he would actually say, like, I'm having a lot of spasms, but you couldn't see anything move because his joints were so contracted. So you would see the muscle twitching between the joints, but nothing really moved. And so even with the backlift and pump in place that you see there, he really needed some custom seating that was built around his needs. And so he needed to have his wheelchair replaced, and it needed to be sip and puff, because that's the only drive system that he was going to use. So when we looked at his old chair, that was how it was built. Does anyone see anything wrong with that? I mean, it doesn't look great from without him in it, but it's what he needed based on how his body was built. So we actually took very similar dimensions towards his new chair, and he was so comfortable in that new chair, but it was it doesn't look like it should look, but it was very functional for him. And so again, it's not about us and what we think it should be. It's as much about what the client needs and how they interact with it, and then me doing my best with all of my friends and help that I need to try to match what they need with what is possible and what's out there for us to put together. So my last lady ended up having a angiosarcoma and a right hip dysarticulation. And she was having significant acquired scoliosis, no kidding, after having one whole hip removed. And she had a 7.5-inch discrepancy when she was sitting between her right PSIS and her left PSIS. I mean, what kind of cushion could come up with that difference? Even custom. That's huge difference. So just looking at her on her immersion cushion that she'd had right after surgery, like, it's obvious where all that pressure goes, right? It's obvious that her right IT is taking probably half of her body weight, if not more, just because of the way she has to sit. So we didn't come up with something really special for a cushion. I got with my P&O friends and got a sitting orthosis made, because the other piece of this was she's active. She was able to use forearm crutches to do her transfers, to walk around her house. She's sitting in other chairs. She's sitting in the car. They're going to her daughter's house where she's not taking her wheelchair because it's level entry and they could get in. So it was really more important that she has something wearable that could help take up that difference and stabilize her pelvis than worrying about modifying the chair so much that she's not spending that much time in. So to conclude, when we look about wheelchair management, it requires us to have really good knowledge of the medical condition that person has and the needs that we're trying to meet. It also requires us to have knowledge about those equipment options and configurations, and good collaboration with our product specialists to say, I'm the body expert, you're the product expert. I want the body to do this. What can we do with the products that you have? Or why would you choose A over B? What can we get? How can we make it work together? And the ability to match that need with the right equipment, and that requires us to listen. We may have the best ideas, but if that person doesn't think that's going to work for them, or they're not convinced that it's going to be helpful, or if it takes too much time, then it's not going to work. And so it'll be abandoned. So why do it in the first place? We really need to listen to what their needs are and make sure that we're incorporating that into that plan. And then we need to have a really good understanding of insurance. And sometimes it's not about you don't get it because you don't have insurance. It's more about they put the rules out there. This is their game. I will just learn how to play it. And there's many ways you can still get the job done with the requirements out there. You just got to throw it back to them as I'm following your guidelines. And by those guidelines, these things are covered and you should cover them. And here's the medical changes that have happened in the last 2 years, which is why they need the new equipment. And then the ability to work collaboratively with all of our disciplines, that we do have to do education with primary care or with nursing about the things that might be different, but we need to hear from them, what's that longevity going to be? What do they look like when they're not in clinic or not in the hospital and at our disposal? So really making sure the whole team is involved in helping to make good information available so the client can make good decisions on their own, especially when wounds are present. So these are my references, and I'm happy to take any questions or any discussion that you have. So thank you. If you have any questions, there are 2 mics up here. Otherwise, if you do shout them out, I'll try to I'll say them because I guess it's being recorded, which they didn't tell me until the last minute.
Question on the one of the cases and the little guy with CP. Can you go back to that picture? Like, what? I just was wondering what's going on with the harness, the H harness. It looks like it was almost like slung across.
So it's not an H harness. This was a different kind of harness that we tried for him because the H harness was in the way with he had a feeding tube still that they would use sometimes, and so because of his asymmetrical pull, we actually got an asymmetrical harness, so he just had loading over one, and then it was able to distribute the pressure. So that actually went on the new back, because Mom liked it so much. It was really easy to get in and out, but it kind of helped just support him pulled a little bit away from him turning his head like this all the time, so it kind of helped stabilize him, and it made about 1.5 inches difference on where we had to place the headrest compared to when we didn't have it on. So it really did help kind of center his body a little bit.
And then just curious with your patients that are in dialysis and chairs, have you asked about the patients that might have do not resuscitate or do not intubate advanced directives?
Yes, because this gentleman did, and they said it doesn't matter because in our clinic, because the dialysis versus the DNR, DNI is kind of a conflict anyway because it's a life-saving measure. And so their option was, well, he could go have dialysis at home, and then whatever he does at home, he does at home. But he kept declining to have it at home. So then we were like, well, okay, you have a choice and you're choosing to go to dialysis, then this is the best we can do. But we'd actually gone down and pressure mapped the dialysis chairs with the dialysis nurses and the physicians, and they were like, this is great information, but no, you still can't, I'm not gonna change my practice. I'm like, okay, well, we've done what we can do.
I work with folks mostly with ALS, and a lot of them, as they progress, can't breathe and can't swallow if they're laying flat. And so bed and chair position is always tricky, right? They won't do pressure relief. They won't lie on their side. They won't lie on their back. They have to have the head of the bed up. And so just curious if you or anybody else has figured out any sort of mattress option, because they're up in that V. They've got all the pressure right on their tailbone. I mean, it's a huge problem.
So, and I don't have any great answers for that because it's so client specific that sometimes I know people have taken to sleeping in their chairs, which no one here is going to advocate for. But at the same time, at least the chair is made for them. And so my concern with people is that they're spending more and more time in bed with their head elevated, and so they're losing that trunk control. So they're sliding to the side, and aside from just the pressure here, there's just no control of their trunk. So they don't end up sleeping and doing better there. They actually they're stuck. So I say if you're not gonna sleep, be in your chair, do your position changes, so at least we have some lateral control, we've got some posterior control, and at least it can change. The bed, you get stuck and you're just stuck.
Yeah, the chair, they just won't do it in the chair either.
Yeah.
Because even with the mask and the breathing apparatus on, they still have swallowing problems. Yeah, it's a challenge.
Yeah,
Thank
and
you.
I don't have any great ones for that either. Anyone else? I have 1 minute left.
Hello. Related to the lady with the hip disarticulation, many years ago we had a woman with a hemipelvectomy come into our clinic for a custom cushion. She was quite independently mobile with crutches, but she couldn't sit. So she wanted a cushion where she could sit in the car or sit at the kitchen table, and we did a custom contour, which looked beautifully like a prosthetic socket for that missing side. The problem was she was missing her right side, so to get into the passenger seat of the car, she'd have to climb over this thing. She had a prosthesis made that she wasn't going to learn how to use, and we had the prosthetics orthotics department was across the hall from me, so they modified the prosthetic socket into
Yep.
the prosthetic butt.
Into the bucket. Yeah. Yeah, and
that
that's
just worked great for him. The following week, we had another gentleman with a hemipelvectomy who was a younger man and effectively using his prosthesis. The only two I've ever seen 20 years ago.
Yeah, and that's not uncommon for us because we have a spine or a cancer center too. So that is one of the more radical amputations that we see. And I think, you know, the thing that is hard for me, and we're still working on, is that the P&O get to talk to the patient before they go to surgery, talking about all this stuff, but the seating clinic people don't. And I'm like, you know, you're going to be using a chair more than you're going to use a prosthesis, at least initially, and sometimes given body habitus, age, and overall health and wellness prior to surgery. If anyone's ever seen someone using a prosthesis after hemipelvectomy, it is extremely, like, it's laborsome. Like, young people struggle with it, and sometimes they abandon those and just move with crutches because they're fast and they're light. And so to have someone who's older or someone who is struggling with mobility up to this point, I really wait and say, let's really talk about what lifestyle is going to look like and what you need, because a sitting orthosis can go a long ways just for them to consider the idea of having a prosthetic. But sometimes the idea is, well, we're going to do this, and then you're going to walk, and you're going to do all that. But it's not always taking into account how that person's going to recover. And so, I just can't say enough about the sitting orthosis and the opportunities there for people with those amputations, because I don't have to then focus on the seating system as the end all be all, because it allows them so many other opportunities. And again, typically if their other leg is doing pretty good, they're more mobile. They're light, they're fast, they can do the things they want to do. I'm out of time, so thank you everyone. I really appreciate you coming, and I hope you have a great rest of the conference. Thank you.